Somewhere in the ancient world, a man has not slept in 3 days, not because of fever, not because of war, because of a stone the size of a grape sitting inside his bladder, and every few minutes his body tries to pass it and cannot. You know exactly where that pain lives, lower abdomen, deep and specific, a pressure that builds until it stops being pressure and becomes something you don't have a word for. He doesn't have a word for it either. He just has the stone. And in a moment, you're going to understand why men who survived what came next considered themselves the lucky ones. A bladder stone is exactly what it sounds like. Minerals crystallizing out of urine. Slowly, over months or years, until the deposit is large enough to scrape the bladder wall with every movement, block the flow of urine entirely, or migrate somewhere it absolutely cannot fit. The pain is not abstract. It is localized, insistent, and cumulative. A small stone can pass on its own, at a cost you'd rather not think about. A large one cannot. It simply stays. And as it stays, it grows. And as it grows, the blockage worsens. The infection climbs. The kidneys begin their slow surrender. Waiting was not patience. Waiting was a death sentence written in weeks. This was not a rare problem. It was not a problem confined to one corner of the world. Paleopathologists have found stones in Egyptian mummies, in medieval skeletons, in remains stretching back thousands of years. Children got them. Men got them most often because of the geometry of male anatomy. And so the problem was old enough that by the time Hippocrates was writing in the 5th century BCE, it was already familiar enough to refuse. The Hippocratic Oath, the version that has come down to us, contains one of the most debated lines in medical history. The physician swears that he will not cut for stone, leaving that to men who are practitioners of this work. Read that line slowly. It does not say the operation is impossible. It says the physician will not do it. The cut was known. The cut was already being done. But the learned physician, the man who studied humors and prognosis and the dignity of medicine, would not be the one holding the blade. So who would? The work fell to a separate class. Itinerant cutters, men who traveled between towns, who advertised the one thing they could do, and who lived or died professionally by whether their patients survived long enough to walk out. They were not surgeons in the modern sense. They were specialists in a single brutal procedure, carrying their instruments town to town the way a blacksmith carries his hammers. The learned physicians looked down on them. The patients, when the stone became unbearable, sent for them anyway. This is the logic of ancient and medieval lithotomy, the term itself from the Greek, lithos for stone and tome for cutting. You arrived as a patient, and here the cold fact of it begins. You were restrained, not sedated, not unconscious in any meaningful way, because nothing available to those practitioners could put you fully under. You were held, by assistance, by ropes, by the weight of other men pressing your body into position. The classical position placed you on your back with your legs folded up and apart, heels near your own chest, everything exposed and opened and without defense. What came next was a cut between the legs into the perineum, the soft tissue below the scrotum, aiming blind toward a stone the surgeon could only feel by pressing a finger inside the rectum to push the bladder down toward the blade. The incision had to be large enough to extract the stone. It had to avoid the arteries nearby. It had to be made quickly because speed was the only mercy available, and it had to be followed by extraction without tearing the bladder wall, without severing anything that would bleed without stopping. The Roman physician Celsus, writing in the 1st century CE, described the procedure in his work De Medicina with the calm of someone recording a recipe. He was specific about hand placement, about the angle of the cut, about how to manipulate the stone toward the opening. His calm does not mean the reality was calm. His calm means he was writing for physicians who needed to understand the logic of it, not be reminded of the screaming. The screaming was already understood. Shock was the immediate enemy. Blood loss was a second. Infection, arriving silently in the days after, was the patient. Executioner, a man who survived the table still had to survive the wound. And the wound was deep, intentional, and open to everything the ancient world could not keep out of it. The stone was out, but the body it had been cut from was not yet safe, not even close. And yet they kept coming, town after town, patient after patient, because the alternative to the blade was already killing them by the time they arrived. So the question is not why they did it. The question is why it sometimes worked. Picture the calculus a lithotomist carried into every operation. Not cruelty, not ignorance. A very specific set of competing probabilities, and the man on the table had already lost the safer one. The stone was not going to dissolve. It was not going to pass. It had passed the threshold where waiting meant kidney failure, sepsis, a slow erosion of function that ended the same way as the blade, just, slower, and without the chance of walking away. The surgeon knew this. The patient knew this. Everyone in the room knew this. What they were attempting was not a gamble against good odds. It was a gamble against certain loss. And there is a difference between those two things that matters enormously when you are the one being held down. Speed was the first instrument, not the knife. Speed. Every additional second of cutting was another second of blood loss, another second of exposure, another second for shock to settle into the body and refuse to leave. The fastest lithotomists in the pre-modern world were timed by witnesses. 30 seconds, 45, a minute for a difficult stone. These were not performances for observers. They were survival margins. A man who could locate the stone by feel, open the tissue cleanly, and extract without tearing in under a minute gave his patient a different body to recover in than the one left behind by a surgeon who took 3. Positioning mattered for the same reason. Get the angles wrong and you were cutting through the wrong structures. Get them right and the blade found the path Celsus had already mapped, the one with the fewest catastrophic consequences built into it, because Celsus had done the work of thinking. His account in De Medicina isn't a historical curiosity. It is evidence of a tradition that had already been refined, corrected, and transmitted by the 1st century CE. He wasn't inventing the procedure. He was recording what a long line of practitioners had learned by doing it and dying by getting it wrong, and adjusting and passing the adjustment forward. He specified where to place the fingers. He specified the direction of the incision. He specified how to manage the stone if it shifted. That level of precision does not come from one man watching one operation. It comes from a tradition old enough to have made every mistake already, and specific enough to have named the mistakes so the next generation didn't have to repeat them from scratch. That is not ignorance. That is a primitive but real empiricism running in the only laboratory available, the human body, under conditions no one would choose. And it did improve. Not quickly. Not in any way that would satisfy a modern surgical theater. But the anatomy got clearer. By the 16th century, practitioners working in Italy and France were approaching the procedure with a more precise understanding of what the blade was moving through. The instruments became more deliberate. Dilators for widening the incision without tearing. Gorgets to guide the blade along a defined path. Forceps shaped for extraction rather than improvised from whatever was available. Mortality did not fall to something comfortable, but it fell, somewhere in the range of 10 to 20% by the later pre-modern period, depending on the account, the practitioner, and how honestly the records were kept, which was not always honestly. Those numbers carry uncertainty and should, but the direction of travel is real. The thing was becoming less lethal as the understanding behind it deepened, even without anything that would count today as sterile technique, anesthesia, or germ theory. The failure cases are not hard to find. There is a particular weight to the 17th century Dutch cases, where lithotomists working in Amsterdam left records clear enough to follow. Men who went in for the stone and survived the cut but died in the days after from wound infection, from the fever that arrived on the 3rd day and did not leave. The stone was out. The body it had been extracted from was simply not able to close the distance between the operation and recovery without something crossing the wound that no one yet knew to exclude. The practitioners were not incompetent. They were operating at the edge of what was mechanically achievable without the knowledge that would not exist for another 2 centuries. They lost patients they had technically succeeded on. That is its own particular grief, and the record suggests they knew it. And yet the patients kept arriving. Children with stones too large to pass. Men in their 40s who had spent 2 years managing pain that had stopped being manageable. They arrived and they submitted to the position, the restraints, the blade, the extraction, and the days of waiting after, because the body they were living in had become a country they could not survive. Urinary obstruction is not a philosophical problem. It is a physical one with a physical end, and anyone who reached the lithotomist's table had already lived through enough to understand that the surgery was not the worst option available. The worst option had been the last several months. The surgery was the door out of them. That is the reversal the procedure's history keeps insisting on. We look at it from the outside and see only the brutality of the cut. They looked at it from inside a body that was failing and saw something different. A chance. A specific, costly, uncertain, real chance that the stone would be out and the body would close and the world would stop narrowing to a single point of pressure below the abdomen. Some of them took that chance and lost. Some of them took it and walked back into their lives and grew old and were buried with skeletons that showed, to anyone who looked carefully enough, the healed scar tissue of what had been done to them. The man from the opening, the one who has not slept in 3 days, is not exceptional. He is the common case. And the thing he was waiting on, the thing the itinerant cutter with his instruments and his 2 minutes of terrible precision could give him, was not health exactly. It was the return of a body that worked, a body that was simply his again, no longer occupied by something that had been slowly claiming more of it every day. The stone forced the cut. The cut made survival possible. And the patience to keep doing it better, generation by generation, in the dark before anyone understood why wounds turn bad, is the same patience that makes every tool we trust in medicine today. They were not waiting for modern science to save them. They were building the floor it stands on.